Okay, perfect. So just as a quick introduction, I'm the Director of Sleep Surgery in the Department of Otolaryngology at Vanderbilt in Nashville. I'm board certified in both otolaryngology and sleep medicine, and the medical and surgical practice of sleep medicine constitutes the bulk of my clinical practice. So, I'll get right into some of the draft LCD considerations, which starts on slide 3. And outside of that, I'd say thank you all for the opportunity and the honor to speak with you. I'm glad that there's been work in this direction. So the first of these, overall, I think the draft policy is really excellent and well done. But there were a couple comments that I had that I thought deserved consideration. The first, on my third slide, is the draft language for the fifth coverage indication, which states, and I'll just read it out loud, that shared decision-making with the sleep medicine physician who determines that the beneficiary demonstrates CPAP failure, defined as AHI greater than 15, or CPAP intolerance, defined as CPAP machine-derived compliance, reporting with usage less than 4 hours a night for at least 70% of the nights in 1 month, or the CPAP has been returned despite CPAP interface and or setting optimizations. I'd like to recommend that this language be edited to read documentation by the implanting provider that the beneficiary demonstrates CPAP failure, again defined as AHI greater than 15, or CPAP intolerance using the above criteria, despite CPAP interface and or setting optimizations. There are two main reasons I'd like to recommend this. One, documentation of CPAP failure or intolerance by the implanting provider brings coverage indication into agreement with other approved surgical therapies for sleep apnea, obstructive sleep apnea, acknowledging the role of the implanting provider in counseling patients regarding surgical efficacy and other treatment options. I can tell you from my own personal experience and some of the data that's available that many patients with previous CPAP failure or intolerance refuse retrial due to severe prior intolerance. And so the language as it stands suggests that patients should have to go back through that whole initial loop possibly for redemonstration potentially of intolerance. And this forces clearly intolerant patients to undergo reconsultation and possible CPAP retrial that creates unnecessary system costs and inefficiencies, and it increases the risk of loss to follow-up and may traumatize patients with prior severe intolerance. I'll move from there into my next comment, which is on the next slide, slide 4, and this is with regard to the draft language for credentialing and accreditation standards. This states that excluding routine post-op care by the implanting surgeon, initial consultation and post-implant evaluation and management of beneficiaries appropriate for hypoglossal stimulation devices must be approved by board-eligible or board-certified sleep physicians with qualifications as outlined. Additionally, sleep studies shall be performed in an accredited sleep facility as stated in LCD L36953. I would recommend that this language be changed to read initial consultation, routine postoperative care, and initial post-implant device activation of beneficiaries appropriate for hypoglossal nerve stimulator devices may be completed by an appropriately trained and manufacturer-certified implanting physician, and that therapy evaluation and management must be performed by board-eligible or board-certified sleep physicians with qualifications as outlined in LCD L36593. And additionally, sleep studies shall be performed in an accredited sleep facility as stated in LCD L36953, with the exception of device efficacy studies where no therapy adjustments are planned, which may also be performed using a home sleep apnea test. And again, sort of two main reasons to justify this. One is that most patients that seek initial consultation with an implanting surgeon after previously failing attempts at CPAP elsewhere in the community and requiring this reconsultation with a sleep physician to establish demographic candidacy creates excess system costs and inefficiencies, especially when implant criteria are already well defined. Sorry, there's quite a bit of background noise. I'll continue with that comment and say, allowing initial consultation with implanting surgeons brings this criteria into agreement with that of other covered surgical procedures for sleep apnea, and surgeons are uniquely equipped and qualified to appropriately assess the anatomy of the upper airway for initial candidacy assessment, including through upper airway endoscopy. With regard to my second point from that revised language suggestion, permitting therapy efficacy assessment through home sleep apnea testing will decrease post-operative costs. It may be necessary for patients that are intolerant of the sleep facility environment, so I don't think that there should be an absolute requirement that all assessments are done in the lab setting. Two more quick comments, and then I'll wrap it up here. My fifth slide is with regard to the draft language for drug-induced sleep endoscopy or DICE training. And the current language states that due to documented inconsistency in determining if complete concentric collapse is present, the inserting provider shall be certified by the FDA-approved manufacturer's second opinion service of validation by a video clip submissions of at least 80% agreement in at least 15 consecutive studies, and then inserting provider shall have documentation to submit to this contractor if necessary. I would recommend that this be edited to read, the inserting provider shall be certified by an FDA-approved manufacturer's second opinion service of validation by achieving at least 80% agreement for presence of complete concentric collapse of the palate across video clip submissions in at least 10 consecutive studies. And most importantly, prior to validation, implanting providers will have shared decision-making review of DICE video clips with the manufacturer's validation service, where the opinion of the validation service regarding presence of complete concentric collapse shall supersede that of the implanting provider, and inserting provider shall have documentation to submit to this contractor if necessary. Two justifications for this. The current LCD language lacks clarity regarding what aspect of DICE evaluation actually requires agreement, and inter-rater variability is known to exist across scoring at multiple levels and structures in drug-induced sleep endoscopy, and I think it's important to clarify this. And then the current LCD language actually implies that new implanting providers must accrue at minimum 15 DICE exams and achieve validation prior to any patient being eligible for implant, and this can actually be a very time-consuming and laborious process. It can take months, depriving eligible patients of access to treatment, and so I would recommend that it's a shared decision-making process until that point of certification. My last comment is with regard to the draft language for coverage indications. That's on my last slide there. And it essentially says beneficiaries who are or who plan to become pregnant. I would recommend this just be changed to read beneficiaries who are pregnant. And the rationale here is that there's no medical evidence for future pregnancy being a contraindication for implant or treatment. And available evidence for this therapy does show that electrical fields generated by the device are localized and do not interfere with other implanted devices capable of electrical field detection, such as cardiac pacemakers, and would be expected to have even less of an impact even at further distances in the body, such as the abdomen or pelvis. And that's it for me in terms of my comments. I'm happy to take any questions if they are out there.